afternoon. I'll talk to this afternoon about FlexView micro lens. You all know what presbyopia is, and the issue there is because of loss of accommodation, the focal point ends up being behind the retina. And there are multiple approaches to try to treat it. And my question is, why intracorneal implants? Of course, you can use multifocal IOLs. What's happening here? And it's highly invasive. You can do monovision, but you're going to lose quite a lot of distance visual acuity. You can use corneal refractive surgery with laser, but you remove tissue and it's non-reversible. And you can also use corneal inlays, which long-term apparently had some issues. And of course, the subject of today is the intracorneal lens that I'm going to present. Historically, the whole field started with Jose Barraquer, who was a famous ophthalmologist, and he tried to use cryolate lenticles to treat it. And then in 1964, he tried to use plexiglass, but ended up with necrosis and failure. Dick Lindstrom from the United States tried to use polysulfone inlay, but they also failed. And then at the end of the 90s, he tried to use hydrogel small implants. He did a manual cut with a scalpel and then put them in. He did about 8 implants, but because he could not make it consistent, it was abandoned. So now, as far as corneal inlays, there are 3 techniques to deal with presbyopia. One is the pinhole effect, the other one is the corneal reshaping, and the final one, which I'll be focusing on, is the refractive lens. The first one is AcuFocus Karma. Some of you may be familiar or implanted those. It's a pinhole effect, and it uses a solid disc with a 1.8 millimeter hole in the middle. The second one is to change the shape of the cornea. It's done by revision optics with raindrop. It's about 2 millimeter hydrogel, and you are reshaping the cornea by putting it under a flap of a LASIK. And finally, the BioVision Presbia, which was originally called InView, become FlexiView. It's a hydrophilic lens, about 3.2 millimeter in diameter, and it's an intracorneal lens. The AcuFocus shown here is basically a ring with about 8,000 holes, and the idea is that you're creating a pinhole effect. Here is shown how you implant it into the cornea. But unfortunately, if you remove it after a while, and this is also a shot of a few years after removing it, you could see an imprint on the cornea, which is going to affect the visual. You can see it here, and it's very clearly shown here as an artifact. The other inlay is the raindrop. It's the hydrogel, about 2 millimeters, and they're designed to put under a flap, a thin flap, because you need to reshape the cornea, the anterior surface. And this is a short video of the technique for the raindrop. That's a standard flap for LASIK. The whole idea was to use the LASIK as a standard procedure and just add that to it. The problem with this is that you cannot really now see the visual axis, and you're kind of guessing by putting the implant on. It's a very small implant, and you have to be also very careful when you're going to put the flap back so it doesn't move out of its position. But we also ask you to wait for about 60 seconds to get it dry before you actually close the flap. I'll skip that one for sake of time. And what happened was the raindrop was recalled by the FDA in 2019, and the main reason that 75% of the patients developed corneal haze. The same kind of unfortunate situation happened with camera, and it was removed in 2022 because of the danger of vision loss after removal of the implant, as I just showed you. The FlexiView micro lens, and I'll try to maybe explain the design here, is basically a ring with an optical surface on the periphery with no power in the middle, and a hole in the center for nutrients transport. The thickness of the lens is about 15 micron. It's less than the thickness of a hair. And we developed this optical power between 1.5 to 3.5 diopters, and you implant it in the stroma, and in a depth of about 300 microns. What helps us is the fact that when you do in a distance vision, usually the pupil is bigger, and with your near vision, it's smaller. So we took the advantage of that parameter, and we did the layout of ray tracing to see what happens if we put the implant, as I just shown you the design. And it shows quite well that you're going to get a reasonable good focal point. What's the principle? When you implant it into the cornea, for near vision, the center acts like a pinhole, and it focuses onto the retina. And then when you have the lights that going through the actually periphery of the lens, they also focus onto the retina. And then anything above that is blocked by the pupil because it's more constricted. For far vision, the center is obviously focused because it's neutral. And then you get a bit of a blaring effect to those yellow rays that because of the add-on power. And then because of the pupil is a bit wider, the rays outside the implant also focus into the retina. So you'd expect to have reasonable outcome out of that. So this is the simulation of 4 millimeters for distance vision, no micro lens with micro lens. And this is a simulation, as you see on the left side, the patient cannot read, it doesn't recognize what it is, but with the micro lens, it's 3 millimeter diameter, and this simulation, you can clearly read the letters. We've done a lot of animal implants and biocompatibility studies, all the bench tests, but this is a result of 12 months of a rabbit. It's quite clear and clean. You don't see any deposits. We also have done 2 studies with pig eyes. We implanted in 14 pigs. It was done twice. 2 different series of tests, and we had no effect on it. Here there is a cross section of histology, and you could see no reaction to the implant because it's extremely biocompatible. The first system that we did was quite a few years ago. We didn't have the lasers available in those days, so we developed a special microkeratome that will make only pockets. It's not going to make a flap. And it was made with the electronic control unit, the handpiece, the delivery system, and the implant itself. So the objective was to develop an implant we at the time called InView, that it's a small lens. It can be removed if necessary, be no permanent loss of corneal tissue, so it's additive procedure, completely biocompatible, which is shown already by all our animal studies, allows corneal metabolism and maintain corneal strength. You don't make a flap, you're making actually a small pocket. This is our first type of series of clinical trials, and here is a video that shows you the procedure. You first mark the visual axis, and then you apply the microkeratome. It's a specialized one. You could see it here. You see also the marking. So the markings, and the objective is to put the lens around that. Now we've used a special delivery system to insert the implant. It was a proprietary inserter. You can see it here. Up. This is the inserter. It has a little plunger that pushes the implant onto its position. Because it's generally not that easy to find where the position is, you'll later on need to reposition the implant, and you'll see it in a minute. But this is the delivery. You have to do it gently. You see just the edge of the lens. And you very gently remove the inserter. Now you need to use a cannula to position it in the center. Those are the results of a 12-month study. We did it in Mexico, 27 patients. You see very clearly that there is a benefit and an increase in uncorrected near visual acuity. This is before, this is after. And as far as best corrected near visual acuity, there's no difference whether you're wearing glasses or the implant. So you're reaching the same effect as wearing glasses for near. As far as uncorrected distance visual acuity, you can see you lose quite a bit. In this case, later on, you'll see it's about 2 lines you lose on average compared to the pre-op condition. But you'll lose substantially less if you're going to do monovision. This is the best corrected, and it's reasonably well. Then we looked into using an OCT to see how the implant looks inside the cornea. You'll see it quite nicely here. And this is the microkeratome cut. It starts gradually, and at the time we did 250 microns. So the initial clinical evaluation, we certainly shown that we can correct the presbyopia, and usually within 1 week, the surgery, after surgery, the patient regained good near vision. Loss of uncorrected distance visual was mostly unnoticed, approximately 2 lines. Implant in non-dominant eye we did, and the brain processed the binocular vision, and over time there was an improvement in ability to see near and far. And what we found was that the patients were highly satisfied. There was no need for reading glasses. In most cases, cosmetically it's appealing. You can't even see it, like you see the camera by AcuFocus, and about more than 90% of the patients were satisfied. Now we reached the age of the femtosecond laser. In the early phase, we had the 60 kilohertz lasers, and we started the study in Crete, in Greece. Why we decided to use the laser? Because you see, this is with a microkeratome, the cut, 250, and you get a very accurate cut of 250 with the femtosecond laser. And we use the parameters for a LASIK, but with a deep cut at 250 microns. So the preliminary evaluation for this technique using a laser, we did a study between 3 and 6 months with 32 eyes. And the age group was between 41 to 59. This is courtesy of Professor Pelliceris. At the time, we used the normal LASIK protocol, but we put a mask to block the cut, the peripheral cut for the LASIK flap, and we're only allowed to small cut that we'll use in the tunnel to get in. You could see it here. That's the side cut. Now you see the shape. You open it with a separator, and that's done at this time. It was at 250 microns. In this case, we did a bit of irrigation, but it's not necessary at all because it creates some edema, and you have it takes longer to recover. That's the delivery system, which was shown earlier in animation. And again, very slowly, you try to push the lens into position. That's where the lens is. You can see some reflection. And finally, use a cannula to reposition it. You're putting it underneath the lens in the center, and you move it to a position where you get the blinking light. So that's where the visual axis. You'll see it here, the blinking light. That's it, well centered. Those are the results, and you cannot see it with a naked eye, but of course with a slit lamp examination, you see the retroillumination nice and clean. These are the results of a wavefront, and you can see very clearly that what I call the donut effect, just the periphery was added on as power, where the center was ignored in the periphery. So that what gave us the extra adding power to do the reading for near vision. There's some shots of the procedure. You see a little bit of debris usually coming from the surface of the eye when you use the inserter. Those are the results. The uncorrected near vision after 6 months, you'll see dramatic improvement here, shown in blue. The uncorrected distance vision acuity actually a little bit worse. Again, approximately 2 lines you're losing. As far as the binocular, you hardly see any change. There's a little bit after 6 months, you're still a little bit off, but you're still seeing 20/25 or better. And as far as refraction, we didn't see any change. And here is again distance refraction with no significant change at all. As far as satisfaction, that study, we found that some reason the Mexican were not as happy as the Greek, but nevertheless, we were getting pretty good results. As far as poor, so about 3% only thought it was poor outcome in their perception. So the near vision for presbyopia improved in all cases. And then 1 week after surgery, most patients regained near vision. We've seen no pacification after 6 months. There was a little loss of uncorrected distance visual acuity, and there was also some loss of contrast sensitivity. Now we come to a more advanced age of the femtosecond laser. It's 150 kilohertz, gives you a smoother cut, and we move in that direction. So we did a randomized study here of 150 kilohertz laser, and we did a study of 40 patients for 12 months. Those are the inclusion criteria, and the exclusion criteria. We did not accept pilots or night driver. We were concerned maybe with glare and halo might have some issues, or anybody that had prior surgery or had some diseases. Here you see the result. This is the hole that you have for nutrients transport, and this is, you can go still, the nutrients go around the lens. You see here clearly the lens, but we've gone now from 250 to 300 microns. This is the OCT image before surgery. This is about 1 hour. You see swelling. 1 week, it's swelling almost gone. 1 month, you don't see it, and that's basically after 3 months, it's 300 micron. Wavefront analysis also pretty similar. You see here that donut effect. Now, the most spectacular was the uncorrected near visual acuity improvement. You could see that it's improved quite a lot after 1 week and 1 month, but the best improvement happened after 3 months because of neuroadaptation, and then it stays stable. So, in particular, this study, we gained about 6 lines of EDTRS, and that's quite an impressive outcome for near vision. As far as the best corrected near visual acuity, no difference before and after. And this is the uncorrected near visual acuity by different levels of EDTRS. And you could see that, in essence, we're getting almost 100% saying 20/40 or better. And as far as binocular, there's no change. And uncorrected distance visual acuity and binocular, also no change. Because this procedure, you need to understand, it's designed to operate on both systems, both eyes, for normal daily operations. So the idea there that when you're normally looking around with 2 eyes, you don't see a difference, but you still can read. As far as uncorrected distance visual acuity, you lose about 2 lines. This is in logMAR. And the best corrected, there was no significant change between it, from about 0.01 to 0.03. The best corrected distance visual acuity, and this is an operated eye, and you could see, again, very little change between before and after. Those 40 patients. What about loss of lines? As we had about 2 patients in that series that lost 2 or more lines of visual acuity, but what the surprising part, we had some that actually gained lines, which we cannot explain that. Now, the most important study we did in the United States is a large-scale study. It's a 421 patients were involved in this study. We did the implant at between 280 to 300 microns and do a follow-up of 36 months. And the age group was between 40 and 60. Before surgery, we did a trace analysis, and you see very nicely here was a presbyopic patient that he has only a depth of focus of 0.9 diopters approximately, and a nice peak. After implant, you'll see actually the two peaks because of the bifocal system that we introduced, but the interesting part, you still get some intermediate vision here, and you get a depth of focus of about over 4 diopters, which is quite good. And you'll see it later on in the results. Now, when you do a best corrected refraction, is also important to note, you need to do throughout different focuses, because you may pick up the refraction at this point, doesn't give you the optimal. You need to go across until you get the best outcome, either through near vision or through the distant vision, but you need to do it across that range to do the refraction. Those are the results similar to the other study. You see dramatic improvement, very similar behavior. After 3 months, it's stabilized. And in this case, we gained 5 lines. The previous study was 6 lines, but it's still pretty good. This is by level, the uncorrected near visual acuity, and from what you see, there's hardly any here. We got a pretty good outcome, and this is how it's broken into different levels. As far as 20/40, we aim to get 75% 20/40 or better for near, uncorrected, but we end up with almost 92%. This is 20/40 or better. The best corrected for near visual acuity, there was no change before and after, or very insignificant. Again, it means that it tells you that it actually behaves very similarly to glasses. As far as refraction, no change for a period of about 2 years, a slight minor change of about close to 1/4 of a diopter, and I think this is progression of presbyopia for the young patients that may need in the future, maybe replacing those lenses with the more powerful ones. The uncorrected distant visual acuity, as mentioned, you lose some lines, and you see it here. We only get 72%, we're getting 20/40 or better. That's because of the blaring effect from the add-on power. And you can see here the loss of the 2 lines. This is again broken down, best corrected by levels. And as far as 2030 or 2020, there's hardly any change. Of course, you see changes, those ones that see very well. Or we had a lot of patients we call eagle vision. They had 2015 before surgery. Those ones will suffer with this procedure. So in the future, I would not recommend enrolling patients like that. You really want to enroll 2020, 2025, 2030. The best corrected. So you have here about loss of 1 line. This study, no change in refraction. What's the pleasant surprise was the fact that we improved the intermediate visual acuity. And again, it was shown in that graph I showed you with that hump. And you improve it by 2 lines. Binocularly, no change. In uncorrected distant visual acuity, you can see it by level. It's basically the same. And now we looked at what other potential adverse events we had during that study. What we found that about loss of 2 lines in 36 months, we had about 1.2%. As far as corneal haze, we had about 1.4%. And as far as epithelial defects, we had about 0.7%. The interface debris, due to not being that careful, we had about 1.4%. We did have explants. We had 7.1% explants. And as far as transient line, we only had 0.5%. And most of the explants were actually made due to the fact of neuroadaptation. The patient were not very happy with the outcome, and we took them out. Here are the results of a patient surveillance. And you see that excellent, they consider around 77% felt it was excellent. Only 1.6% thought it was poor. And the question was, how frequently do you use glasses? 73.5% never use glasses at all for any activity. Only 2.7% use glasses when they had to, almost always. Now, with regard to glare and halo, we actually got a pleasant surprise. We expected more. Nobody, but 76% see no glare and halo. Always only 1.1%. We thought we will have more of those. And as far as the question, would you do the surgery again? And we found that 91.3% said yes, they will do it and recommend to others. And only 8.7% said no. And I suspect most of those are those patients that we explanted. And I would like to comment that after explantation, basically everything went back to preoperative conditions. So in summary, from a patient satisfaction point of view, 92.4% said that they're very happy with the outcome. 91.3% said they implanted again. 76% did not use any glasses at all, free of glasses. Only 1.3% in this study used glasses always, compared to 100% used to use it all. So that's a very dramatic improvement in lifestyle. In summary, patient satisfaction with presbyopia FlexView microlens is high, and it is safe and effective procedure. Now, latest news, a few days ago here in the Arabian Peninsula, in Kuwait, we did our first 5 implants. And I would like us to share this exciting video that was done locally. We used a Z8 laser. The previous studies we did it with wavefront and AMO laser. This is Z80, the first time I've ever used it actually. Z80 has a software for making pockets. Here you pick up the implant from a special carrier with the insertion tool, which we designed specifically for that. Then you're putting a cannula and you hold it in the center, the implant, while you remove the instrument. Finally, you position it to your marking. Here you do a bit of smoothing, you're pushing to make sure it all sticks, both surfaces, and that's it. So, thank you very much. And if you have any question, I'm more than happy to answer.
Thank you so much, Professor Vladimir. I have 2 or 3 questions.
Yeah.
So the implant, as you show, is 3.2 millimeter.
Yes.
And the 1.6 millimeter, this is the zone of change.
The 1.6 is zone with no power.
With no power. Okay. And the power comes from the periphery.
The periphery, the little donut.
So, first of all, does it depend on the pupil size of the patient?
We were surprised. We thought so too. Although it helps, as I said, when you're reading it, a little bit smaller, so it actually blocks the peripheral lights. But beyond that, we tried to correlate it in the study to different pupil size. We did not see any difference.
And when you show the eye trace, I show in the trace that it was on 4 millimeter.
Yeah.
4 millimeter. So, does it, if we did the scan of the eye trace on 3 millimeter or 2.5, it will going to give different?
Most likely, yes.
So it can be more. It will be benefit for the patient if it's daylight more than at night. Mesopic.
Well, and at night, at dusk, you will get quite good distant vision.
Yeah.
And when he is reading, usually you read when there's a lot of lights or when you want to read small prints, and the pupil is smaller, it's sometimes less than even 3 millimeters. You get the full benefit of near vision.
And if you implant it and you see some wrinkles second day, what you are going to manage?
Well, can I tell you about those wrinkles? I was puzzling where the hell they come from.
Yeah.
And we've actually just the other day saw it. When you do the femtosecond laser, you'll find out that actually the surface is not that smooth. It's actually wrinkled. The lens takes the shape of the wrinkles. Optically, I don't know if it's going to make a difference, because at the end of the day, it's the rays that going through it get refracted through higher refractiveness and eventually get focused. So kind of the follow-up, the pattern. It may give you a little bit of distortion, but you won't notice it. The brain will filter it anyhow. But you do get those wrinkles.
And in cases of the pupil is not central, you are going to center on the pupil. If it's little bit pupil decentered, you are going to target the pupil where it is, the location of the pupil.
Okay. We are centering it not on the pupil. We're centering on the visual axis. The best one, if you have a laser that you can look at and it blinks, you can center it. Otherwise, you can, again, do it on the slit lamp and mark it. That's where we put it. And sometimes, of course, the pupil is not exactly in line with the visual axis. Up to about 300 microns, it's okay. We don't see any difference. But do not put it on the pupil, because the best place to put it is on the visual axis.
And can we use it with femtosmile or that you can?
I should have had a video there, but because we thought I'll be running out of time, I did not show it to you. But we did do also with Visomax.
Yes.
The trick there is not to open the anterior cut. You only open the posterior cut surface, and then you put it in. We had such implants done in Italy.
Okay.
Any
Thank
other
you. Thank you so
questions?
Much. Any questions? Thank you so much, Vladimir. Thank you.
Thank you.
Thank you so much. Thank you. So we are coming to the last session of the day to end this really beautiful day of ocular surface disease. For myself, I really enjoyed. I learned a lot. So can I ask Oslim? Yes. Professor Singwan. And Dr. Hani Sakla. Okay. So let's start the session till Singwan and Hani comes. So the first talk, it will be around ground round challenging ocular surface disease and expert panel discussion, Oksana. Dear Oksana, we are close friends since more than 5 years now, and she is really super nice. And you have a beautiful country, Ukraine. So let's have the talk.
Dear colleagues, first of all,